What I'm really talking about is more of a story, kind of my evolutionary process over the last 25 years. And I know I don't look old enough. It was when I was born. No, I'm only kidding. I'm actually older than both of the guys here, I think, which is depressing. In any case, let me just see if I can advance this. So first let me tell you 2 seconds about myself, because I'm not going to bore you, and like I said, it's not going to be very technical, and it's not really about the slides. It's about what I'm really saying. I did choose to go to an osteopathic school. You saw that as my degree, and I did a residency in physical medicine and rehab at Albert Einstein, and then a fellowship in pediatric rehab, and since then lots of other things that'll become apparent as I tell you a little bit about my story. But after medical school and after my internship, when I was doing my residency, when I was doing my residency, one of the things that we were taught all through training in rehab, because we treat a lot of neurologic disorders, we treat spinal cord injuries, we treat stroke patients and so on, was that central nervous system does not regenerate. That was back in the 80s and 90s, because as I said, I'm old. And so I started seeing more and more stroke patients in my residency that would come to me 4, 5, 6 years, spinal cord patients, 4, 5, 6 years post-injury, telling me, you know, everybody said I'd max out in my recovery at about 1 year, but you know, I'm regaining new function every day, very slowly, but it's continuing to occur. And so the theory that we all had was that it was only peripheral nerve regeneration, but I started to really question that in my patients. And so what I did, being a stupid resident, was I did a massive literature search for a journal club that I was presenting in front of multiple departments with multiple faculty at Einstein. And I found this amazing set of studies from Scandinavia around 1990-91 that was studying central nervous system regeneration, and they had created lesions in the brains of these primates, which is as close as you can get to studying humans anyway, much better than rat or mouse studies. And they were able to track certain histologically areas of absolute regeneration, and I thought this was just mind-blowing. You know, it completely flew in the face of what I was taught, and it gave a whole different aspect that might open up new treatments for my patients. And so I thought this was incredible. So I presented this from a very naive perspective, and I was literally laughed off the stage in 1991 by my faculty, by these attendings. Now, of course, I'm the one laughing now, 20 plus years later, because it is fact, not fiction. The next sort of phase of my career and my life was shortly after that, when I was doing my fellowship in pediatric rehab. And I was seeing a lot of kids at Kennedy Center at Einstein with autoimmune types of inflammatory disorders. So yes, I was seeing the CNS injuries, the cerebral palsy, but I was also seeing kids with progressive neuromuscular and degenerative disorders. And I was seeing a bunch of kids with autism, even HIV, babies born with HIV who had a lot of neurologic compromise during development. Then I met her. Now in that picture, she's 28, but when I met her, she was 14. And her mother had brought her from Jamaica for treatment for what's called type 2 spinal muscular atrophy. The type she has, the life expectancy is maybe 25 to 28 years. They have progressive severe scoliosis that kills them. That's what her spine looks like, that beautiful young woman. And I knew that this was going to kill her eventually. Nobody wanted to operate on her because it was a neuromuscular disorder. And my passion and my drive for wanting to help, I'm going to cry over her because she's still alive and she's 33. Thank you very much. Now, it wasn't, she has driven me more than any other single person in my career. Because I started to say, what is this about autoimmune disease and progressive inflammatory conditions that is so destructive? And I started seeing more and more of it, even after my fellowship. Now, I do have a skewed population. I see people who seek me out for very specific reasons, but even so, it seemed like there was this increasing presence of autoimmune diseases. But with her, I started to say genetics, inflammation, autoimmune. Clearly we know in spinal muscular atrophy there's a genetic component. It was passed on by both of her parents who had carried a particular gene. It's relatively rare, but we also know that the manifestations are largely driven by the autoimmune system, and that the changes are further driven by the inflammatory reactions. And that's really what we're starting to learn in medicine in the last 5, 6 years. Immunology is a whole different language than what I learned 25 years ago. It's unrecognizable to me, in fact. And we're starting to see, you see even in lay journals and things, you'll read in the Wall Street Journal, every article now about medicine is about inflammation, cardiac disease, hypertension, diabetes, thyroid disease, and so on and so forth. So my theories 20 plus years ago were just theories then, and of course now they're starting to actually become realities. I just put this picture in because this was taken during the same photo shoot, and as I said, she was 28 in the photo. That is her 2-year-old, completely healthy daughter who was born by a normal spontaneous vaginal delivery, which should not have happened with this woman with this diagnosis, and she should be dead. The mother, not the daughter. The daughter is now 7 and fine, and her mother is starting to decline again now. But what we ended up doing with her at that point, because I didn't know about the application even 5 years ago about stem cells clinically, because I was being told in this country, forget it, we're at least 10 years away, it's not happening, it causes cancer, there are ethical issues, all the things we've all heard. I did find a surgeon to operate on her. He was able to reduce a 111-degree curve to 34 degrees, which is quite dramatic, and that prolonged her life, and I think gave her another 10 years because she would have been dead within a year, and her goal was to see her daughter reach teenage years, which I hope she does. Now, she may be too late for stem cells, but it's been the driving factor for me. After that fellowship, I was sort of recruited up to Connecticut to develop a myofascial and musculoskeletal pain program, which I did. And my practice quickly started to evolve more into the musculoskeletal, chronic and acute pain syndromes. And what I was seeing was what I like to call end-stage pain patients. Now, clearly, these aren't the people who are dying of cancer, but I call them end-stage because they'd been everywhere, 10, 20 years, massive workups, and no answers. And they weren't getting better with the traditional treatments. And so those are the people that found their way into my office. Wow. And that's very challenging, as most of you know. So I kept asking myself through this whole process, why? Why are they not getting better? Why are they not responding to the traditional treatments? Then I moved back to New York to start my private practice in '96, and I met a woman I'll call Phyllis. She was sort of the next turning point in my career. She came to me with the classic low back, buttock, sciatic distribution pain complaints, but she started talking about other things that she was suffering from, the biggest of which was gastrointestinal. She was having severe cramping, bloating, distension, chronic constipation, almost seemed like IBS but not, and almost seemed like Crohn's or gluten enteropathies, all the things that we talk about. And she was fully tested for it. Everything was always negative. She was tested at every major facility in the New York area. But I was looking at her pain, and everybody was compartmentalizing it and saying these were separate issues. They're not separate issues. I started seeing this pattern emerge, which I'll get into in a minute. Phyllis's GI problems, in fact, became so much more the prominent feature that I had to do something about it. And so I actually found a surgeon up at Yale who was willing to scope her, do a laparoscopic theoretical repair of an inguinal hernia. And he called me that night, and he said, I have never seen anything like this in my life, but this woman's entire abdomen is a mass of scar tissue. That was a fascinating discovery for me, because then I thought, why? She's had no trauma, she's had no abdominal surgery. Why is she developing spontaneous formation of scar tissue? So it started me thinking even more about these autoimmune hyperproliferative states, and does that have something to do with why she wasn't responding to the treatments for her back pain and her sciatica? The sad note to that story is that that woman died 9 months later from malnutrition in 1997 in the United States, which I find unacceptable, completely unacceptable. So then the next emerging pattern in my practice then, I said they're all musculoskeletal complaints, but I started looking at people's histories and listening to them, and there were a myriad of other complaints that I know were related, were clearly inflammatory. And here's a little list, partial list. This is not complete. Obviously, my patients have musculoskeletal complaints. They have joint disease, disc disease, nerve compression, muscle pain, etc. But the other theme that I was seeing was that many of them have a baseline hypermobility and ligamentous laxity, and they'd come into my office flinging their arms all over the place and their legs all over the place and say, I'm so tight, I'm so restricted. But no doctor believed them because they had full range of motion, right? How do you assess for that and look at somebody's pain level and take them seriously? But I was seeing this over and over again. Well, they're always tight. Phyllis was developing spontaneous scar tissue. Is there something fascial going on that has to do with the inflammatory process that's driven by your own body attacking itself, autoimmune? Now, I already had the knowledge of the other autoimmune diseases from my residency with MS and lupus and so on, rheumatoid arthritis. My patients also had gastrointestinal complaints, like I said. Is it IBS? Is it colitis? Is it Crohn's? Is it gluten enteropathy? None of the tests were positive, and yet they had the symptoms of all of these things at various times. A lot of dermatologic manifestations. You know, typical eczema psoriasis, we know that's autoimmune, but these patients, even without that, were coming in saying, I get rashes all the time, clearly histamine releases, allergic types of reactions. Some of them were coming in telling me also they had asthma-like symptoms, but their studies for asthma were negative. They were never diagnosed as having any type of restrictive or obstructive lung disease. What was going on with them? Is this also autoimmune? In fact, one of my patients ended up spending a week out in Colorado. There's a huge institute for pulmonary diseases, and after the week, this was about 5 years ago, their diagnosis, autoimmune. Go back to New Jersey and New York and keep seeing the pulmonologist and the pain doctor you're seeing, me. They all would tell me they have environmental sensitivities and food allergies and other autoimmune manifestations that I touched on, thyroid disease, diabetes, lupus, etc. So there was emerging an even bigger story here, something that was connected that we're missing in this country a lot. I want to say, by the way, this is a perfect moment for me to say, I have no financial incentive here. I do not get paid by Panama. They don't give me a piece of money when I send patients down, and they're not paying me for this. So my motivation is very pure with this in a way. Sorry, that was a little digression. So another common theme I was seeing was that my patients, and this was even a bigger amazing moment for me, they started talking about, well, you know, I haven't been quite the same since I was, someone's here who, with the very story, since I was thrown from that horse when I was 14. Or I haven't been the same since I had mono at 12. Or, you know, and so on, or Lyme disease that I suffered with CNS Lyme disease. And many of the patients coming to me were saying they still had Lyme disease, chronic Lyme disease. Well, I had very severe Lyme disease, and I don't think they have chronic Lyme disease. I think they have post-Lyme autoimmune disease, because I think these things triggered their genetic predisposition towards autoimmune diseases. And I think that many of us are born with that, but for decades that hasn't become a major manifestation. But I think we are assaulted by things in our world, whether it's physical trauma, whether it's environmental, whether it's infectious, whatever. There is something that is waking up this autoimmune process in the body, and then we can't shut it off. So what do we do about this? So these themes are emerging. Why? Why? What do we do? Again, my big question. So I started to theorize that these patients really, as I said, were manifesting an undifferentiated autoimmune disease with inflammatory components, but I still couldn't prove this because all the lab tests that I was doing were normal, all the rheumatologic workups, and I would send them to the rheumatologist, the endocrinologist, the immunologist, etc. The classic markers for inflammatory disease were normal, the SED rates, the C-reactive proteins, the rheumatologic workup, rheumatoid factor, the spondyloarthropathies, Sjogren's disease, ANA for lupus. The ANA is the only thing that goes back and forth, a little positive and then negative. Everything else negative. So all the other doctors were looking at me like I had 5 heads, and this wasn't real, and my patients were really crazy. My patients are not crazy. These are real people seeking answers for their pain. Then, one of my patients introduced me to an immunologist at Rutgers in New Jersey, brilliant, brilliant research scientist, who unfortunately next month is losing her post there because of finances. In any case, she listened to my story about these patients, because I'm a clinician, I'm not a scientist. I don't know the science that Dr. Reardon is going to talk to you about. I'm familiar with it and I'm learning it, but I treat people clinically. So I presented the clinical findings in some of the limited labs that I had, and she said, you know what? I want to study this in my lab. I want to do tests that are not done in a traditional lab to see if I can prove that there is in fact an inflammatory proliferative process and what might be going on with these patients. And so she first studied the family that brought me to her. And this was an interesting point also, because here we have the genetic component. There were 3 generations in this family with autoimmune disease. So she studied all 3 generations. And sure enough, there were certain intriguing facts, certain levels of pro-inflammatory cytokines that were off the charts, certain levels of an interferon gamma that causes fibroblast formation, scar tissue, fascia. It all started making sense to me. So now we needed to do something bigger. You cannot come back in if you leave. Sorry, the thing about that. I've lectured a lot. I have a thing about it. They don't even know I'm talking about them, but that's okay. In any case, they, where was I? Oh yeah. So there's the familial trend. So then we thought, let's get more of my patients over there and start studying them. So we ended up doing 25 patients, 25 controls, and sure enough, every one of my patients tested out the same way. This is not a coincidence. But then I still didn't know what to do, right? So I have this amazing data, but how do we treat it? That's the next step. So the typical treatments in this country, and this is very limited. Obviously, my patients, a lot of them talk about nutritional things. They get on diets that are considered anti-inflammatory diets, less sugar, less carbs, maybe less gluten, even though they've tested negative for gluten enteropathies. They started implementing these things, acupuncture, physical therapy, all the things we've all been through and heard about. But medication-wise, what doctors have to offer is extremely limited. So what do? We give patients anti-inflammatories, muscle relaxants, pain medications. Those aren't the answer. Maybe it palliates a little bit. We give people, the rheumatologist will give you methotrexate, Plaquenil, prednisone, and a whole myriad of other drugs. This is, again, just a limited list. Now, the steroid always makes my patients feel better, but they can't stay on it. And in fact, if you look back at the history of what I'm seeing, in the 50s and 60s, there was a diagnosis given to my mother's generation, always middle-aged women who complained of pain, and they all had polymyalgia rheumatica and were all given 5 milligrams of prednisone for the rest of their lives. Well, their bones deteriorated, their joints deteriorated, they developed cataracts and so on, and so, big, beautiful buffalo humps in these women, very attractive look, but they felt better. Clearly, that was autoimmune and inflammatory. Then it became fibromyalgia, and so on and so forth. Then the third line are the biologics that Dr. Paz alluded to that are very dangerous, Humira and Enbrel. They really suppress your immune system, and a lot of my patients either couldn't tolerate it or didn't want to do it. And then, of course, we have intravenous immunoglobulins, where you infuse the immunoglobulins to boost the immune system, and that is a very tough protocol to undertake. It's ongoing, it's forever, it's not touching the actual cause of what's really going on. So none of these things were quite acceptable to my patients, and as I said, they're all palliative. So what else? What's the next step? I will not talk for, I know you're probably bored and want to go outside, but so then the next step, another phase. Another patient of mine said, I want you to come to Israel and meet this doctor that I heard about at Hadassah. So they brought me to Israel about 6 years ago, and I brought him the data I had from the doctor in New Jersey, from Dr. Giannucci. And I presented the clinical findings. This was a doctor who was the head of the bone marrow transplant unit at Hadassah. Very, very powerful, conservative, really this kind of doctor, right? And he sat there and he said to me, before I even showed him any data, he said, all I treat is cancer patients, and a lot of my cancer patients develop autoimmune disease after treatment with chemotherapeutic agents. It's a pretty common development after. So he had to say to himself, well, how can I take this the next step? And so several years earlier, he had started extracting bone marrow, which he did all the time anyway, from his now post-cancer patients who had autoimmune disease. They started processing the bone marrow to isolate the stem cells, the mesenchymal stem cells, and then they would put it through a 4 to 6 week culture or expansion process. So basically, they exponentially grew those stem cells from that patient, and then they would infuse it intravenously into the patients. And he said to me, I promise you, I am stopping the autoimmune disease in its tracks, and in some cases reversing it. He looks at my data. He said, you're right. Don't let them discourage you in the United States. Keep going. This is the right direction. And then I said, well, what about the damage to the joints that's been done that I see, and the muscles and the discs and all of this? He said, that's your job. So then I had another job to come home and try to figure out how to do. That began the hardest part of my journey, which is the last 5 or 6 years, because I did a lot of research, a lot of traveling, and bottom line is I would never tell one of my patients to go somewhere that I didn't feel comfortable being treated as well. It also led to a lot of confusion for me. And I'm a doctor, and I was confused, looking over the internet, visiting programs, and it's insane what you see on there. And if there's one thing I can get across to you today, it is please be careful about what you read on the internet. You will see, especially in the last couple of years, all of these ads for stay in the United States, get stem cell treatments right here in the US, and we will cure, and they list 20 diseases, right? From your own fat, from your own bone marrow. Bullshit. Excuse me, is there a child in the audience? Bullshit. Bullshit, bullshit, bullshit. And then they start confusing what is PRP and what is prolotherapy and are there stem cells there? No. But there is some good work happening. You just have to understand how to distinguish between what you're reading, and I would be very, very, very cautious. And that last sentence is probably the most important for me, which is that the more I learn, the less I know about this. There is no question we have a long way to go. You start looking, and you can make yourself crazy. Even I make myself crazy. Cell type, cell safety, cell harvesting, cell expansion, cell delivery. To sell or not to sell. What is it already? It makes you insane. Is it autologous? Is it allogeneic? Can we expand them? Can we not? Is it safe? Is it legal? What is legal in the US? Does this create limitations for us here? Is it safe to travel outside the US? So here I was faced with even more questions than in the very beginning when I was just trying to figure out the clinical presentation and the science behind it. There are answers to these questions. Is it safe? It's safe if you choose the right program and the cells are isolated properly and you have faith in what's being done there. Yes, it can be very safe. It can also be very dangerous. Obviously, we have a lot of ethical issues in this country because of the whole embryonic stem cell thing around 2000, 2001. That's not an issue. Oh, I'm sorry. That's not an issue. This is not an ethical issue any longer. I am stunned even these days when someone will say to me, how many babies did you have to kill for that? And I'm just stunned. Last week, I got an email from someone who's in this audience whose parents, who's hoping to get treatment, whose parents were speaking to a practicing physician friend of theirs who literally said, oh no, you can get AIDS or hepatitis from stem cells. This is ignorance. If you're going to a place that you trust that maybe your doctor has vetted, hopefully, as I have, you're not going to get these things. This is tested for. It's been tested for decades, even on blood transfusion since the AIDS days. So this is nonsense. What we can do in the US is very limited because the FDA limits us to same-day procedures. Well, Dr. Paz just showed you a graph about how the robustness, they like to call it, or the viability of those stem cells diminish as we get older. So you're somewhat limited, number one, by the viability of those cells and the number of them, but number two, we're not allowed to expand or grow them. So whatever you get from that one isolation, that one draw, is what you can infuse. Now that may be good enough for a sports injury, a tendon injury. It is not good enough for systemic, progressive autoimmune disorders. The other thing is you have to be very careful because yes, there are stem cells in bone marrow, there are stem cells in fat. My patients know that I push the envelope, but I'm very conservative about certain things. I have not jumped on that bandwagon in this country because I do not yet think the technology for same-day processing of the fat cells is safe. And a lot of people are going for that in this country because they promise the cures. And what's better than to extract some fat? Everybody wants fat extracted anyway. So then you get these stem cells, but are they processed properly? Is it safe? I worry that if I infuse it intravenously and there's not enough washes or passes of this solution, what if these cells coagulate or aggregate and form what's called a fat emboli and can kill you? What if you inject it into a joint because you don't know the science and what you're doing and it forms a lipid cyst or a fat cyst, which can be catastrophic and urgent surgery? So I started looking at the limitations we have in this country. Now the bone marrow processing, there's new equipment coming out and I may start doing it because I think that is safe. Bigger question that I was confronted with my patients, is it safe to travel outside of the United States? Yes and no. Okay, there is a program that a number of my patients have gone to through a group. There's an IV center, Lyme disease, chronic fatigue center in New York. A bunch of them have all been going to a program in Mexico. I do not mean to denigrate any particular program in Mexico or otherwise. I will tell you, however, these patients were coming back feeling great for 3 or 4 weeks, and it's cheap. It's really cheap. And so they'd come back feeling great for 3 or 4 weeks and then decline. And then they'd go back because they could afford it. Well, I'll tell you, in the year, they've spent more money than they would have going to Panama or another reputable program. And I researched it because I was obligated to, and I was scared. The medical director is a lovely man, and he has wonderful intentions, but he could not tell me the derivation of the cells, how they were processed, how they were transported, the safety, the outcomes, nothing. No prognostication. I did not trust him. Patients were coming back feeling better because they were getting pumped up with growth factor and vitamin drips and amino acids such as glutathione. So sure, they felt better for a few weeks. But again, not only was it not attacking the underlying problem, but the bigger issue is that what's going to happen 5 years from now? What cells are they using? I don't know. Are they safe? I do not know. So I could never condone something like that. Bottom line for me is do no harm, no matter what. And it's very hard to sit in front of a patient who's suffering, who tells you, well, 3 of my friends just got back from Mexico and they feel so much better. And for me to turn around and say, don't go. Continue suffering? That's not an okay option either. So, I'm struggling a little bit. So as Dr. Paz said, and I'm almost done, about 3 years ago, I was in Arizona visiting my sister, and I was doing my usual internet search and looking at stem cell things, and I saw that they were giving a seminar from Panama there, and I thought, what can I lose? Let me go. And so I went, and for the first time since Israel, and since Dr. Giannucci in New Jersey, and since my chairman at Columbia was like, you're crazy, forget it, there's no such thing yet as clinical application of stem cells, it's not safe, I started hearing Dr. Reardon speaking in my language. Now he is a scientist and he's a great talker and he'll be next and you'll learn a lot from him. But he started speaking a language that I recognized from my patients, and so I was very excited, and I went to talk to him after and to Dr. Paz, and then I went to Panama. And one of the things, because I had been at several programs before that already, one of the things that struck me about their program, and again, I'm not selling it. There are a lot of good programs out there. Please understand. I hope they're not in the room right now. There are a lot of good programs. Anyway, but one of the things that struck me was the total transparency, as he said, when I went there. I could go into the lab. I could talk to the technicians. I could talk to any of the patients. I could talk to the treating doctors. I could look at charts. I could talk to the nurses. There was nothing hidden there. There was no other agenda. And the other thing that struck me was that this was not a spa. This was not a feel-good place where you're getting drips and walking out feeling good. This was a place that was seriously looking at what's going to happen 3 months down the line, 6 months down the line, because that's where the recovery occurs. It's not that instant fix. There is no miracle in this world. There's no panacea. There is serious science, looking at the basics of the science, knowing that you're in a safe place, and then trusting that you're willing to do it and being able to afford it, which is the other dilemma I always have, because my practice has also evolved into one of patients that can afford me, because as you can imagine, I don't take insurance, I spend a lot of time with people, and I'm not selling my practice. I'm very busy. But these are the kinds of things that are outside of certain people's reach. I will tell you, however, I've brought many groups down there. Every single person that's been there, have they been magically cured? No. But every single person, the first thing they say is they trust it, it's clean, they believe in it. The second thing is that every single patient has gotten something out of it. And they've all gone back, which also speaks volumes to me, 2 and 3 times if they could afford it. So enough about Panama. It's really about stem cells. It's really about healing. It's really about decreasing the inflammatory and autoimmune process in our bodies. And at the end of the day, that's really what it's about. So thank you very much. Oh, yeah.